Welcome back to another episode of Fertility Ain't Fair, the podcast. I am your host, Britt, and I am, as always, excited to have a phenomenal guest hopping into our podcast to give us a lot of information, as always. But today we are focusing on perimenopause because I'm going to be honest in that I feel like it was one more thing on my health journey that I feel like was never really discussed with me. And then I'm at the point in my life now where I'm like, is this perimenopause? Is this perimenopause? So we thought a good conversation to have was to talk about what that looks like individually and also what it looks like from a fertility standpoint. And also if you are like I have been, in the throes of infertility and doing IVF for multiple years, can I still move forward? If I'm in this space of perimenopause, can I still move forward with certain fertility treatments? So all of that on this episode of Fertility Ain't Fair. But as always, I'm not alone. And I am happy to have Dr. Peggy hopping in. And so, of course, I'm going to give her credentials very briefly because she has, y'all, like the credits. Okay. Heavy hitter on our podcast. We have Dr. Peggy, who is a board certified women's health nurse practitioner and CEO of Trust Women's Healthcare, a renowned advocate for health equity. She is specializing in GYN care, obstetrics, and menopause, specifically focusing on women of color and their needs. Thank you. She has been named a 2025 Healthcare Hero for New York's 10th District, and she is also the creator of the Menopause Connection. Through her clinical work and media presence, she is redefining midlife care and empowering women to lead their own health journeys with confidence. So, Dr. Peggy, welcome to Fertility Ain't Fair.
Thank you, Brittany, for having me. I'm so delighted to talk about this so needed conversations, and we just got to continue it, right?
Yes.
Because there's a lot of misinformation out there. So I'm happy to be here.
Let's do it. Let's debunk all the myths. So before we jump into all of that, though, I have to ask you the question that I have for all of my guests at the very top as we get to know you. How are you currently defining yourself in this current life season?
Ooh, that's a good one. I think I'm focusing on just being true to myself and being true to my mission and vision of what life looks like. I'm a wife, I'm a mother, I am a friend, I am a sister. I'm also a entrepreneur and a clinician. So as you can see, I have a lot of different roles. So I have to remain true to me and be able to redefine what that looks like for me. It may be different for other people, right? But I want to make sure that I'm showing up in these spaces and I am an example. And I'm also just making a mark in society, and also self-care, just making sure that I have time for myself and that I'm able to sleep at night and do it all the next day. So it can pivot from day to day depending upon what's going on. But I think that this is where I am in my midlife journey. And I encourage women to find their peace and their happiness and whatever that looks like. And no one else can dictate what that would look like for you.
Love that. Thank you for sharing that. So as we start the conversation, I think we always should level set on definitions, right? So, because again, I feel like I was kind of blindsided by what is this thing? What is this transition pause before you get to the big one? And I want to know, has the clinical definition of perimenopause changed over the years, or how are you currently able to define that for our audience?
So I think the clinical definition of perimenopause has remained the same. I think our outlooks have been different and what we define it. Because again, menopause is just over the last 5 years has really blown up where women are like, no, we have to do something. And there has to be something out there that we can do to get through this midlife change. So we spend so much time concentrating on menopause and forgot about perimenopause, where women are still experiencing the same symptoms and they are still getting their menstrual cycles. So they're not quite in menopause, but now they're in this transition phase, which is what perimenopause is. But no one knows how to treat them. So again, women are not feeling like themselves.
Yeah.
So like you said, we need to start with definition because I think it's very, very important, especially to your listeners. Perimenopause is that transition. It can happen anywhere from 7 to 10 years before your last menstrual cycle. In women of color, it lasts longer and it's more severe. Perimenopause can set in as early as in your early 40s, believe it or not. I have had some women that are experiencing in their late 20s, believe it or not. And with perimenopause, it always starts with either their menstrual periods are irregular or women are just not feeling like themselves. They notice a shift, a change, something's not right. So it prompts them to go to their different providers, and they're going from one to the next, and they are getting an entire workup, and no one can pinpoint what is actually going on. I always tell women that perimenopause is a diagnosis of exclusion, meaning we want to because a lot of the symptoms, which you don't have to have all, and I will definitely go through the symptoms, they mimic other conditions as well. So what we don't want to do in this day and age is saying, oh, chalk it up to perimenopause, a menopause, where it can be something, another condition that is going on that is left untreated. So I tell women that there's very likely that you might be in perimenopause, but you know what? Let's do the workup. Let's look at everything. Let's dot our I's, cross our T's, and just make sure that there's no other condition that you currently have. And we're just saying, oh, it's perimenopause, and we kind of neglect that. And it can go to this rabbit hole of not being treated. So perimenopause can look like different things for everyone. It can start with the irregular cycle, which means it's shorter, it's longer, it's heavier, it's lighter, whatever that may mean for you. You may or may not get hot flashes. You may or may not get night sweats. You may just be irritable for no reason. You may start to have insomnia where you're up this witching hour of 2, 3 in the morning. You're more fatigued. Your sexual desire has decreased. You notice some vaginal changes, like, I'm not as lubricated during intercourse as I used to be, or I'm having more vaginal infections like bacterial vaginosis or yeast infections, or I'm getting more urinary tract infections, or I'm having these palpitations. Like all of a sudden, I start having palpitations and I don't know why, or I'm a little bit more anxious. I used to be able to fly hours on a plane, not being okay, but now I get very anxious on a plane. I don't know what's going on. So it can look like a multitude of symptoms, but it's important to get evaluated. And if you are not getting the answers that you need, there are menopause specialists like myself out there that can really listen, because it's very important to listen to women because we know what's going on with ourselves, and to really be able to get down to it. And like I said, it is a diagnosis of exclusion. And whereas menopause is that last final period, 12 months after that last final period. And again, another myth is that once you have that 12 months last final period, all those symptoms that I discussed will be gone. And that is definitely a myth. Women spend about 40% of their lives in menopause. And
wait, time out. What? I've never heard that before. Wow.
Yeah.
I guess when you look at an average lifespan,
Correct.
And you look at, again, how many years can account for this pause space. Wow.
Yeah.
That changes my whole psyche.
Yes. So now if you think about it, as young girls, we had to get used to really just being young girls. And then all of a sudden we have this hormonal shift and we get our menstrual cycles. Then we got to get used to that. Then we go through life. And for some of us, we are able to bear children, get pregnant. Then we go through that shift. Then we have to shift through the postpartum period. Then now, once we finish childbearing, we may get or not get to this comfortable level in our lives where, okay, used to having our menstrual cycles, we're used to doing this, okay, it's great. And then boom, perimenopause hits in. It's like we have to readjust again. So women go through go through so many changes during life. And I always say that anyone who is born with an ovary will go through this transition. Yeah. No one is excluded. The difference is the severity of symptoms and the type of symptoms you have.
Yeah. And I'm so glad that you broke down that this is not just a physical transition, right? Because I feel like we hear a lot about, I will say, the menopause symptoms or perimenopause symptoms. And I feel like a lot of it is focused on the physical things, right, that you might feel or might experience. And to your point, you may not get all the symptoms and you have to be able to get evaluated on what's happening. But the fact that it is, emotional, right? It could be anxiety, it could be depression, it could be you just don't feel right, you're irritable, right? Those are other things outside of those physical things that are usually the pinpoint for this is what this is. And I feel like that's super important because if you're not having some of the physical symptoms, but you just know mentally things are not right, that's a really important note to be able to, document what's happening and then take that your provider and kind of get some more information.
Absolutely.
So we mentioned some of those symptoms, and I think, it's also hard, like you said, because a lot of these symptoms also mimic other things or they're generic, right? Like fatigue, anxiety, sleep disturbances. That could be literally you had a bad day at work, right? So,
Correct.
like, so how do you, I know you mentioned the workup. So are there any other things that you all do in your practice or in your experience that can really definitively help someone say this is perimenopause and distinguish between life stages and phases and just regular life ups and downs, and this is actually a medical condition and here's how we're going to go about kind of managing through this?
So when we have our patients coming to our office, and I work with 4 other amazing clinicians, we are all on the same page. And this is where I opened Trust Women's Healthcare because I wanted to create a platform and experience for women. I think first it's important to listen. It takes time. We're in the exam room with women, just really listening and honing in and trying to decipher, okay, what it may or may not be. And sometimes it may not be established with one appointment. It may take several appointments for us to get to the conclusion. So first is taking a detailed history, making sure that they're up to date with all preventative screenings. So what we're doing is we're ruling things out. So want to know if there's been any life changes. Have there been any medications? Has there been any trauma? How are their relationships at home? Are their family members or friends noticing something? Are they noticing certain shifts in their bodies or their system? Have they spoken to other providers, right? Because I also want to know, have you started the workup? Have you addressed this with other providers and what their thoughts were, right? Because a lot of other clinicians are not fully versed around this midlife transition. And one thing that we absolutely do not do is dismiss your symptoms. We address every single concern. And I think it's important for women to know that you need to go to a clinician that will address your concerns so that you feel that you're being heard. And I'm here to say that you are not crazy. I get women come into my office all the time saying, I'm going crazy. I'm like, you're not crazy. This is real. And the validation alone speaks volumes. And then we're able to break down that barrier, especially if they've gone to many clinicians and they haven't been heard. So by the time they get to me, it's like, it's another person. And I have to go through the story again. And then they're going to tell me the same thing. So sometimes validation definitely helps break down that fear. And we're able to together partner to be able to come to a conclusion. And sometimes I may need to refer you to certain specialists because, for example, if you're having palpitations, I may say, okay, you may need to see cardiology and make sure that there's nothing going on with your heart. Or you may need to see neurology to make sure that brain fog, which is another symptom, is not something underlining in the brain. Or I may need to send you to rheumatology to make sure that there's not an autoimmune disorder that you're currently battling with. So again, diagnosis of exclusion. There is no test specifically that will confirm perimenopause. It is a clinical symptom. So when women come in and they're like, oh, I got my labs drawn, and they say, I'm not in perimenopause. I want to let you know that your ovaries are still trying to work. So when we test your hormones, it is based on what your ovaries are doing at that particular day. It can be on a high or it could be on a low. Who knows? But again, it's still trying to work. Whereas in menopause, it's done, and it's not going to resume. It's not going to come back. So I think that it's important for women to have their questions, to go in fully armed with the information, to have the detail, and also to know your numbers. Because again, is it that you're having hot flashes because now you've developed diabetes or your blood pressure is elevated? A very common symptom is this weight gain. All of a sudden, the diet is still the same. I'm still exercising 5 days a week, but I'm putting on weight. So again, I can't stress enough that it's important to do the evaluation. No one person journey is the same. No one person transition is the same, but it can take several appointments. And that's the frustrating part as well, because it's time. And then I'm also finding that, perimenopause is showing up in their day to day, whether it's in their careers, in their home life. And that's what really scares women, because something that they've been doing for a long time and they've mastered their career, they're on this trajectory, and now they're questioning whether they can do their job. And that's very scary, especially women in any type of industry, any type of level. And that's where we come in and trying to help you, really deal with this transition in the best way possible with all the different options that's available.
Yeah. And I mean, just you saying that, we listen to our patients, and that shouldn't feel like a warm hug, but it does, because so many of us, again, it's already taxing and exhausting to go to different providers and try to find, your dream team, right? But then when you get there, and to your point, you don't feel validated, you are coming in with this weight, you feel crazy, you feel X, Y, and Z. And the fact that your team really does validate every single symptom or every single concern is just, it's so important. And you mentioned the labs and having, labs tell you this or that. And I think, again, that's a myth, that I can just go in and get a fertility workup and I'm going to walk out and have, definitive answers on what's going on. So let's go there. We already know now that there is no one test to give you a definitive answer. But I feel like when I got into the infertility space, there was a lot of, I guess, value on your AMH, right? Yeah. And your FSH and all these different acronyms, things that I didn't even know existed until I was, pushed into this space unexpectedly. So, and I think you've kind of mentioned this, but like, what are the other limitations on, I guess, relying on things like that? Because again, we are in a space where we want information and we want it quickly, and like, what's happening, tell me. But it's really not a crystal ball, right? And so I think you mentioned that, whatever's happening in that moment, it's more of a snapshot and not like a realistic evaluation on your current state of your fertility. So, are there any other things that you would recommend in terms of, labs or workups, or if someone doesn't even know how to ask for those things, like what would you tell them to ask for in terms of, I want to get as much information as possible about, the current fertility that I have in my body, if that makes sense.
No, that makes perfect sense. And it's important to be able to be armed with the information so that when you go in to see your clinician, that you are requesting certain things. So you mentioned the AMH, or your anti-Müllerian hormone. It's one of those key biomarkers for your ovarian reserve. It kind of gives us just a snapshot of what your ovarian reserve is. And it can be measured at any point during the menstrual cycle. So we instituted just a baseline AMH for all patients starting at age 30, just because we were finding that women were, had infertility. They started having irregular cycles in their early to mid 30s. And when we would run the AMH, we see that it is low. They have a low ovarian reserve. And to have a low ovarian reserve prior to age 35, it's almost like, okay, well, what's going on? That means that your ovaries are not producing enough follicles, that your fertility can be in jeopardy. We do it for any woman that comes in with irregular cycles, but at age 30, we find like that is like a good sweet spot if women are having no symptoms. And what we were finding is women were having low AMHs that were asymptomatic, meaning no symptoms, like they were doing well. And the question becomes, do they want children? And do they want to bear children? Do they want to get pregnant? And when we give them that information, If it's great, it's a great ovarian reserve, no problem. We know it declines after age 35. But the AMH, when it's low and you're in your early 30s, if you didn't have this test ran, when you were ready to conceive, then that's when infertility comes into place. And this is something that could have been prevented, meaning could have been addressed much early on. So that is one of the things that I am a very advocate on, women knowing their AMHs if they want children in the future. Even if you're unsure, it is something to really request so that you have an idea of what that looks like. I believe in options. And the AMH gives us you options. So if, for example, if I have a 30-year-old with a low AMH, let's say it's less than 1, that conversation looks very different than the 30-year-old that has an AMH of 3. So that AMH of less than 1 at 30 is like, okay, I'm referring you to a fertility specialist because you need to freeze your eggs so that you have a chance of having a biological child, because the AMH declines. And again, the AMH can be variable, meaning what's going on with your life. If you have high stressors, if you're currently on certain contraceptives, that can, it could be flawed. But I think having that number is a good start. The FSH kind of gives us an indication if you're having irregular periods or you're having all the symptoms that I discussed. It gives us an idea that are you entering perimenopause or menopause, or if you have something called premature ovarian insufficiency, meaning you are going through menopause in your 30s before age 40, believe it or not.
Yep.
And the management for that is completely different than a woman who's in their 40s. Mm-hmm. So those are the questions that I implore your listeners to really ask. And again, you don't need to know all the information, but just, can I get my AMH ran? Or if I'm having irregular periods, don't sit on it. It's not normal for you not to have a menstrual cycle without an explanation. And again, we are born with this intuition. If we feel like something is not right, just ask the question. And if you don't get the answer, unfortunately, you have to get a second, third opinion.
Yeah. I am so glad to hear that you have created this baseline to just get information for options. Because again, I wish that someone had, first of all, told me what an AMH was, before I turned, 30 plus, and got into the space of, it was critical to know what was happening because, things weren't happening. But I think, again, to have that baseline and to be able to ask for that. And that's something that I tell a lot of girlfriends or younger girlfriends who I meet, same questions, do you think you want to have children? Is that important to you? Ask for this test. So I love that your clinic is doing that and making it a standard versus like the exception. Because I think, again, so many women are not being, put in a position to either address critical issues, right? So it does not become a problem or a barrier for them. Things could, to your point, have been managed much differently, right? Or helped or fixed or found out upon, right? And so maybe you would not have to go through the IVFs and all of that, because that's a whole other level of talk about hormones and disruption and all the other things. But I love that is an option for people coming to your practice. And I hope that other clinicians or providers are leaning more into that as just something that's very simple. It's a blood test. I'm like, you guys, this is not hard. It's not, something that you have to, it's very simple. I think it should be standard in OB practices and as well as other providers. So you mentioned the decline at 35, or the natural decline, right? And again, we're talking about natural decline, again, there's other, as I mentioned, factors that, you could be having these issues prior to 30 or 35, right? Those are specific. But let's talk about that. If you are in, let's say, perimenopause, you've confirmed it. Are you still ovulating? Are you still able to, naturally conceive, right? And then also, are you able to either start or continue if you needed to do IVF, for example? Like, are you still able to have these different options during the perimenopause phase?
The answer is yes to all of the above, with a caveat, right? If you're in perimenopause, yes, you can still conceive. You can still get pregnant and you can still have a successful pregnancy. However, it depends on where you are in your perimenopause journey. Again, if you're having these irregular cycles, you will just, it's timing when that ovulation occurs. So that's the conversation that we have, that you're in perimenopause, we're addressing your perimenopausal symptoms, but we also have to, if you are don't want any children, don't want to get pregnant, we have to discuss contraception as well, because there is an instance that you can get pregnant. So we have that conversation as well. When it comes to IVF, yes, IVF can be an option. However, it depends on your age. And it depends on if you can use your own eggs or not. Because especially now, over the age of 46, there are a lot of fertility practices that are not utilizing your own eggs. So what does that look like? And so that's why I start the conversation very early, and women to just really start thinking about conception. Because what you do, again, it goes back to options. You want to always have the option to conceive. You don't want that taken away from you. So I don't think the conversation there's never too early to have the conversation. But, again, it depends on what that looks like. And I always also say that it may not only be you, infertility just doesn't lie with the gestational carrier. It can be other factors as well. But it's important for us to help guide you through this journey and to make sure that you are set up for success for your fertility journey, for your pregnancy, and things that we can address and really manage beforehand is always the best option.
Yeah. That's important. And again, I think we're just talking about, again, knowing your options, knowing what to ask. Again, you don't want to, if possible, be blindsided, by having something taken from you that you never knew was in danger, right? So I think we have to also address, again, the natural progression of life. When I first heard that fertility was like off the cliff at 35, I was like, what? We should have been talking at 25, because you don't know how long it might, you just don't know, right?
And like, women are delaying childbearing. Like, women are getting pregnant later and later in life. So now we have to reshift the focus, right? Yeah. And really, then it starts with a simple question. And I think I ask all patients that, do you want children, or do you want more children? Right. If I hear maybe, I'm not sure, all right, let's talk about it, what that looks like for you.
Yeah.
Because if you're not 110% sure, I feel like it's my responsibility to really arm you with the information, what that looks like for you moving forward.
Yeah. So what are some of the, I guess, general health risks? If we are talking about that advanced maternal age, I hate the term geriatric pregnancy. I feel like it should go away.
We as clinicians, we don't use geriatric pregnancy anymore. We do say advanced maternal age.
Okay, good.
And again, that looks different, right? Mm-hmm. There's an age, and this is, this 35 years old has been advanced maternal age for quite some time. A lot of the data that has come out in recent years that women are having successful pregnancies from age 40 to 45. So again, I think it's having the updated information, seeing your clinician, having the conversation. However, but there are still risks involved. There are always risks, whether you're 25, 35, or 45. And it is very important to discuss what that looks like for you.
Yeah. Yeah. Something else I feel like you mentioned that I wanted to go back to. You mentioned, and we probably don't know why, but I'm just curious. You mentioned that women of color, Black women, typically have a longer, I think it was either perimenopause or menopause, like, I guess, runway. And you said that symptoms can be also more severe. Do we have any indication? Because I feel like we just have everything worse. Like, it's for us, and so I'm just like, wow, like, I guess I'm always, of course, curious, and I'm sure you are also, as a clinician who sees this every single day, like, why are we just always down bad with certain things? But so do we have any indication, or have you, I don't know, any studies that can tell us why seemingly we have this longer window for this, and why our symptoms, I guess, show up so much differently than others?
So I believe it's multifactorial. I think that there is structural racism that also plays a part in it, with implicit bias, because again, it is longer because historically, Black women's symptoms are ignored and dismissed. So if your symptoms are ignored and dismissed, you go through it a little bit longer before it is addressed. So we have that factor. We also have conditions that go undiagnosed, or we have more severe, such as high blood pressure, diabetes, just based on history and genetics. There was this study, it was called the straw study, that studied women over decades. And that's where it came out that found that women of color had these symptoms. They reported more severe symptoms. There is also a lack of education and access. Healthcare is broken. I say this all the time. I don't know what the solution is. I would like to think that I am trying to be part of the solution and change the narrative. But again, if there is lack of access to providers who are fully versed on midlife health, if you are experiencing certain symptoms and you go to that provider that is lacking education, or you don't have the providers in your area to address it, then that goes longer and it becomes more severe. Hot flashes, for example, can be exacerbated by high blood pressure. Most people don't know that. There are certain conditions that if you treat and you address, maybe can help your perimenopausal symptoms. But again, I feel like we are always behind the 8 ball in really getting the information. And then there's the lack of trust in the healthcare system. So there could be something where we can recommend, but there's a reluctance there. So it's really gaining that trust. And I see it all the time, even with representation and being there for my women of color. Being a Black woman clinician, I may make recommendations, but because of the lack of trust in the healthcare system, they still look at me sideways and say, I'm not going to do it. I think that it's okay to make that decision, but I need to know why you're making that decision. Is this something that I didn't counsel you adequately on, or is just something else? I think that saying that patients are not compliant is not okay. We need to kind of delve further as to why. So there is just so many thoughts regarding why it lasts longer and why it's more severe. But I think that it's just the disparities is one of the number one things that kind of causes this, and with the lack of education.
That makes complete sense. Thank you for that. When you talk about treatment and management, and again, 7 to 10 years, right? That's a long part of your life. It's a whole decade of trying to, get yourself back to a place of feeling like yourself again, mentally and physically and emotionally. So what are some, and again, everyone's different, we know that, but what are some of the, I guess, core treatments that are options for treatment, I should say, for treating and managing perimenopause symptoms? And then do those same, I think, treatments apply when you get to menopause, or does it look, a little bit different, how you treat, because they have similar symptoms, right? But it is different life stages. What are some of those things, and do they apply to both sides?
So I want to start off with answering this question saying that you don't get a medal for bearing through this. I hear it all the time. I'm just going to bear through it. You don't get a medal. There is nothing at the end of the line that says that, wow, you did not get you did not take any treatment options when it came to your perimenopausal and menopausal journey. But also, I respect what your journey is. But I just want to say that first. When I counsel women regarding the treatment options, it depends on where they are in their journey. It depends on, because treatment options may look different with premature menopause as opposed to perimenopause and menopause. I always go through hormonal options, non-hormonal options, and supplements. I want to be able to give the gamut. Hormonal therapy, I will tell you, is the most effective. It is the most effective with treating perimenopausal and menopause, specifically menopausal symptoms. Not only does it help with the symptoms, it helps with replacements. Once that ovary is done producing estrogen and progesterone, you don't get it back. We have estrogen receptors all over our bodies. And when we lose them, that's where the symptoms come in and our protection is gone. Our bones are not protected, our minds, our hearts. So I think hormone replacement is not only for symptoms management, but it's also for prevention. So I go through different forms of what that may look like, whether it's a patch or an oral tablet or a gel. We go through everything. That's hormonal therapy. Go through non-hormonal therapy. There are medications that can address symptoms only. They don't replace. So if you're having hot flashes, you're having irritability, there are different medications that, from antidepressants to Veoza, that helps with hot flashes. There are pain medications like gabapentin. I mentioned the antidepressants like paroxetine or Effexor. So there are medications that can address the symptoms. And then I go through supplements. There are a plethora of supplements out there, and it can be overwhelming. And I understand that. So I usually have like my 3 go-tos that I kind of help, kind of narrow down for women. And again, they help with symptoms. There are supplements that have black cohosh that helps with hot flashes. There is turmeric, red clover, wild yams. There are vaginal moisturizers with hyaluronic acid that helps with the vaginal dryness. So there are treatment options of supplements that can help with symptom management. And then also, I want to know what their journey looks like for them. There are some, they're like, listen, hormone therapy, I heard bad things, I'm not doing. And then we debunk that. And, I'm here to say that hormone therapy doesn't initiate cancer. It doesn't initiate cancer. And again, we talk about the study that came out in 2002. We talk about subsequent, we talk about history, family history. We talk about what that looks like. And then we talk about maybe you may not, we can hormone stack. And maybe let's start with one and see how you do with that. In this country, we prescribe birth control like it's nothing. And I want women to know that birth control is actually more hormones than hormone replacement therapy during this transition stage. We talk about the medications, we talk about the side effects, and then I don't like women to make the decision right there. Because again, it's a long appointment and I go through all the different steps, all the different medications, side effects, risks, benefits. They can go home, talk about it with their partners or significant others, do some research, and then we can come back and talk about it some more. Sometimes they do the research before they come and they're like, this is what I want to start based on their history. If there are no contraindications, then we do it that way. But it's important to be armed with the information and to feel that there's shared decision-making in what your journey looks like and what option that you decide to choose.
Love that you are allowing the patients to get the information and make their own decision and not feel forced into decisions. Mm-hmm. And I also love that you are open to, as you mentioned, hormonal, non-hormonal supplements, natural ways to manage your symptoms. Because I feel like a lot of times, and I know I'll speak for myself, the first thing they go to is a drug, right? A drug, a hormonal drug. And I feel like a lot of doctors that I've came across are not open to, the option to have a 360, right? Yes, I might want to take that, but I also want to discuss supplements and I also might want to discuss, non-hormonal options so that I have more of a holistic, viewpoint on how I want to manage. And so many providers, I feel like are just so quick to say, well, this is your only option, right? It's these 3 drugs and this was on the market and this is what we're offering you. And, even when it came to my endometriosis and that management, right, it's very much like, well, I had a doctor tell me it's either surgery or this drug and that's it. And I was like, well, that's not true. I must move on, because and even on the fertility side, again, a lot of doctors were not open to customizing, protocols because it may not have been the tried and true medical, protocol. And it's like, well, I'm different. I'm a different girl. I have different things going on. And, my body may not respond, the way that it's supposed to respond, So I'm just so happy to hear that you give them a full option and a full array of things to make the best decision for them. Because I think truly most people need a customized approach. And that's what's missing in a lot of providers' offices is a customized approach. And so, for those of us who don't have a Dr. Peggy, we have to find somebody or find a number of people to kind of do that.
Absolutely.
Yeah. So if you were able to give you already given us a lot of nuggets, but if you were able to give another just piece of advice to someone, let's say they're in their mid to late 30s going into their 40s and they're on the fence or they still want to have options, right, for their fertility and wellness journey, what's something that you want to leave with them?
I want them to know that it's okay if you don't know. Society's always like, they kind of make women shame in a way if they don't know if they want to bear children or not. Like if they don't bear children, it's like a big thing, like they're cursed. But I want them to know that not knowing or not having the answer is okay. But again, I keep honing in on options. If there's a sliver of you that just may want to bear children, freezing your eggs or having the conversation, the consultation to know what that looks like so that you may have options. I think that when the option has been taken away, and for me to tell someone who desires a pregnancy that it may not happen is heartbreaking. And because I've seen that, I've reshifted my focus and reshifted my counseling so that on the other end, I can give them that advice and counsel them on what they may need to do. And ultimately they make the decision. So knowing what your AMH is, knowing your numbers, if you have certain risk factors, and having that consultation for egg freezing and what that may look like. And also, if you don't get the answer, you get a second or third opinion.
Move on, right?
And you're not crazy. I know it's a lot. I'm saying,
oh my God,
you're not crazy.
Maybe this house episode, like you're not crazy. It could be
not crazy.
Because the validation is real, and finding the safe space in a medical provider that allows you to validate, all of the things and listen to you. And literally, if we can just clone you in every state, we would be better off.
But there are more clinicians like myself that are dedicated to this work. And we're hoping that we'll see a lot more. And I always say that our mothers are the forgotten generation because they didn't have people really advocating for them. And so I'm so happy to know that we are discussing women's health because there's a lack of research, there's a lack of funding within women's health. And I always say women's are the centers of the universe, and we do so many things and we're just forgotten. So I'm so very thankful for this platform that you've created, and also the platform that I've created to be able to be there for women and to really educate regarding their health and wellness.
Perfect segue. So about your platform. So if anyone wants to connect with you, if they happen to also be in New York and they actually want to be a real patient, how can someone reach out, find you, and get to know more about your business and your practice?
Sure. So you can find me at Trust Women's Healthcare. I also have 4 other amazing clinicians that are also available to see, and we all are like-minded. We are all Black women, believe it or not. And we are just really, really passionate about women's health. We have 2 locations, Brooklyn, New York, as well as Deer Park, New York. Deer Park is in Long Island. We are on all social media platforms at Trust Women's Healthcare. Our website is www.trustwomenshealthcare.com. And our phone number is 929-78-TRUST.
Love it. Dr. Peggy, I'm just thankful that we were able to connect. Thank you for agreeing to do this. Thank you for being a light in the space that needs it. And you mentioned you think that you're, in the space of changing things, but you are. There's no thing. You are absolutely changing perspectives and narratives and lives, quite honestly, I'm sure. And so with that being said, this wraps us up for this episode of Fertility Ate for the podcast. As always, listen to all past episodes wherever you get your podcast and on YouTube. And if you have a topic that you want us to dive into, let me know. Slide in my DMs, shoot me an email. If you have a great speaker or someone who you think could be a great guest, let me know. And as always, I'm your forever friend in fertility. And also make sure you sign up for our newsletter. I'm going to be doing a couple of those a year. I told you all I will not spam your inbox, but when we have new things, new information, resources, or amazing episodes, I want to make sure it gets to you all first. So with that being said, thank you again, Dr. Peggy, and we will catch you guys on the next episode of Fertility Ain't Fair.